All right, let's talk about the FAST exam. The FAST exam is probably the most well-known ultrasound examination out there. It's certainly one of the earliest examples of point-of-care ultrasonography. It's been around for a long time. It stands for the Focused Assessment with Sonography in Trauma. The goal of the FAST exam is to rapidly identify free fluid, and because it's in the setting of trauma, free fluid is assumed to be blood. So it's for the rapid identification of blood in the peritoneal space, the pericardial space, the pleural space, and also for the rapid identification of pneumothorax. So really, it is there to identify the most common reasons why a trauma patient is unstable. The traditional indications for the FAST exam are a patient who comes in with thoracoabdominal trauma or polytrauma and is unstable. You go to any trauma bay, if you have a patient who comes in as a trauma activation, whether or not they have thoracoabdominal trauma, they're going to get a FAST exam. So really any major trauma patient now is an indication for a FAST exam. And more now, you're starting to see the use of the FAST exam for the patient with undifferentiated shock. So the patient who may or may not have had trauma, but is in shock and you don't know why. It's become part of the evaluation for undifferentiated shock. The traditional FAST exam has 4 views, and we're going to talk about all these views: the hepatorenal space, the splenorenal space, the perivesicular space around the bladder, and the pericardial space, which you get by doing a subcostal cardiac view. The modern FAST exam, which some people call the extended FAST or the eFAST, takes these 4 views and adds on a couple other views. It adds on paracolic gutter views on both sides, and it adds on views of the pleural space. Most of the time, when people nowadays refer to the FAST exam, they refer to the extended FAST, which includes all these views. When you're choosing a probe, you can choose either the curvilinear probe here, which, like I told you before, is sort of the probe of choice when you're doing anything in the belly, better penetration, better depth of view. Or you can use the phased array probe, which again is the workhorse in acute care and critical care. I prefer to use the phased array probe just because a lot of the FAST exam takes place between the ribs. So the hepatorenal, the splenorenal spaces, and all the pleural views, you have to look in between the ribs. So for that purpose, the phased array probe is better. But some people use the curvilinear probe and do just fine. Either way, you're going to use it in the abdominal preset. And all of the views that we get are in longitudinal axis or transverse axis. So we're going back to that the normal convention of long axis being up to the patient's head, dot up to the head. Transverse axis means dot to the patient's right side. Okay, so either probe, abdominal preset, dot either up to the head or to the right, depending on the view that you're getting. Like I said, the phased array probe fits better between the ribs, so that's the probe that I typically choose. Okay, here are the traditional views in the FAST exam. Usually, because most of the time the sonographer is going to be standing on the patient's right side, usually go in this order. You start in the hepatorenal space. You typically do that with the probe right about at the level of the xiphoid process and placed in the mid-axillary line with the dot pointed up to the head, dot cephalad. You can then go to the other side, to the left side, to look at the splenorenal space. Notice how the splenorenal space, the probe is positioned much more posterior. So not quite the mid-axillary line, but more the posterior axillary line. In this case, they say you drop your knuckles to the bed. So you hold the probe in this underhand grip, knuckles down to the bed, and that's how you get the splenorenal space. Then you go to the perivesicular space. You put the probe just above the pubic bone, just cephalad to the pubic bone, and then have the dot pointed to the patient's right side. And finally, do a pericardial view. Remember, you're keeping everything in the abdominal setting. So the dot is switched when compared with cardiac, the dot is switched to the other side. So in this case, instead of doing your normal subcostal cardiac view where the dot points to the patient's left side, you point the dot to the patient's right side, and that will preserve the anatomic orientation of the subcostal cardiac view. Okay. Here's your extended FAST or the modern day FAST, where you, again, start hepatorenal space and then pick a direction. You either slide up to look in the pleural space to look for free fluid in the pleural space, sort of above the diaphragm, You then slide down to below the inferior pole of the kidney to look at the paracolic gutter to look for free fluid or blood there. Same thing on the left side, splenorenal space, left pleural, left paracolic gutter, then your perivesicular space, your subcostal cardiac view, and then finally you do 2 scan lines in the mid-clavicular line to look for evidence or lack of lung sliding. So in that way, your EFAS is helping you identify free fluid or blood in the belly, around the heart, in the pleural space, and also to identify or to rule out pneumothorax. We'll start by looking at some normal views. Here's a normal hepatorenal space. So what you have here is you have the liver. You can see the diaphragm here, and this is your right kidney. This space, potential space between the liver and kidney, is your hepatorenal space, also known as Morrison's pouch. This is the most dependent region of the peritoneum in the supine patient. So back in the 80s, when they first started to use point-of-care ultrasound in the trauma bay, they would do a single view to look at the hepatorenal space to look for blood in the belly. Because in the supine patient, eventually, because it's the most dependent region of the peritoneum, the blood will eventually go to that space. Okay, but here's your hepatorenal space between the liver and the kidney. This is what it looks like normally. And keep in mind, even though this is a picture, this is a still image, your FAST exam is a very dynamic study. So you're getting in this space, you're finding this view, then you're angling anteriorly, posteriorly, and tilting superiorly, inferiorly to look around, to look through these spaces and to make sure you're not missing any free fluid. So that's your first view. Go to the other side. Like I said, the splenorenal space is typically more posterior to the hepatorenal space. So you're going to reach around, put your knuckles down to the bed to get really posterior to find the spleen in the kidney. And here's the splenorenal space here. Right here is the left diaphragm. It's important to note that a lot of times you would see free fluid or blood below the diaphragm here, so subphrenic, and above the spleen, before you'll start to see free fluid or blood between the spleen and kidney. So again, always look around. It's a dynamic study. So find this view, the splenorenal space, but always angle and tilt to make sure you're looking at the entire region here. Because like I said, sometimes you will see perisplenic or subphrenic fluid collection before you'll see it in the splenorenal space. Okay. Sliding up towards the head, in this case, you're on the right side. Here's the right pleural space. So there's the diaphragm there. And what you're looking to see here is you're looking to see if there's free fluid above the diaphragm in the pleural space. Just like when you're doing your lung ultrasound, you're looking for a pleural effusion, same idea. But in this case, if it's a trauma patient, a pleural effusion would be assumed to be hemothorax. Going the other direction, sliding inferiorly, you can see here's the inferior pole of the kidney here, tail of the liver here, and here is your paracolic gutter. These are all loops of bowel here. You can see that all this air artifact here, loops of bowel, and you're looking for fluid around the bowel. That is your paracolic gutter. You then go and look at your perivesicular space. So you take your ultrasound probe, put a just cephalad to the pubic bone, dot to the patient's right side to get a transverse view of the bladder. And in this case, you're looking at a male, so this is the prostate here. And what you would see is you would see fluid collection. If there were blood, you would see fluid collection between the bladder and the prostate. And as that fluid collection gets bigger and bigger, it's going to horseshoe in sort of a U shape around the bladder there. You can also take the probe and rotate it so that the dot points up to the head to get a long axis view of the bladder, because sometimes you can find very small posterior fluid collections behind the bladder much more effectively from that long axis view than you can from the transverse axis. So oftentimes I will do that. I'll start with a transverse view and then rotate the dot up to the head to get a long axis view of the bladder. And then here is your subcostal cardiac view. Again, this is in your abdominal setting. Notice the dot is on the patient's or on the screen left. And you're in your abdominal setting. So remember, the difference between your abdominal and cardiac settings is going to make it that you're not going to be able to accurately judge things like LV function and things like that in your abdominal setting. The only thing you're looking for here is fluid around the heart. Pericardial effusion which in the trauma patient would be assumed to be hemopericardium. If you're concerned about blunt cardiac injury and cardiomyopathy, you would switch to your cardiac setting and do your standard 6-view cardiac ultrasound to look for evidence of cardiomyopathy secondary to trauma. Okay, but here you're just looking for fluid in the pericardial space. And then finally, then you will do 2 anterior scan lines, left and right, in the midclavicular line to look for lung sliding or lack thereof. Remember, when we talked about lung sliding, we mentioned that visualizing lung sliding very effectively rules out pneumothorax in the scanned interspace. If you do not have lung sliding, you have to consider your pretest probability for pneumothorax. So if it is a patient that came in with thoracic trauma or thoracoabdominal trauma, and they have lack of lung sliding, especially if it's on one side, the pretest probability for pneumothorax in that patient is high, especially if they're unstable, so you can intervene on that. Even though lack of lung sliding per se is not super specific, if they have a high pretest probability for pneumo, you should consider it to be pneumo. Certainly, if you see a lung point, that is specific for pneumothorax regardless of your patient. Now let's look at some abnormals. Here is a positive hepatorenal space. So here is your liver here, your kidney here, and you have an anechoic space here between the liver and the kidney. That is fluid. In your trauma patient, you assume that free fluid is blood. So this is blood in the hepatorenal space. Here is a hemothorax. So again, free fluid or anechoic space here above the diaphragm. You can see a little bit of lung floating in there. So this is free fluid in the pleural space. In the trauma patient, you assume that it is blood and call it a hemothorax and intervene on it. Here's blood in the right paracolic gutter. So you slide the probe down inferior to the kidney here. You can see here is a loop of bowel, and around it is free fluid, which you again assume to be blood. Notice the hepatorenal space is negative here. Okay, so negative hepatorenal space, but you got blood in the paracolic gutter. Also, if you look here, there's some subphrenic blood as well. Here's blood in the perisplenic space. Again, we mentioned oftentimes fluid will collect above the spleen, below the diaphragm first, before it invades the splenorenal space. So always look around. It's a dynamic study. Angle up and down, tilt up and down to make sure you're not missing anything. Sliding down, you're so inferior now that you don't even see the kidney. Here's the left paracolic gutter, and there is free fluid around this bowel here. Here's an example of blood in the perivesicular space. Again, we said bladder, prostate. You can see that this blood here, this fluid collection, is starting to horseshoe around that bladder in a U shape. So this is a positive fast in the perivesicular space. And finally, you have hemopericardium. So this is your subcostal cardiac view in your abdominal preset. And you see free fluid around the heart. And again, in the trauma patient, you assume that that is hemopericardium. And finally, here is a lung point. Like I said, lung point is fairly specific for pneumothorax, whether or not your pretest probability for pneumo is high or not. So in any case, this would be specific for pneumothorax. But again, if you saw lack of lung sliding and a patient has a reason to have a pneumo, like chest trauma or some sort of thoracic intervention, then you would assume it to be pneumothorax. Okay, so the overall utility of the FAST exams, remember, it is a very specific, very goal-directed assessment. You're looking to answer those very specific questions. Is there free fluid or blood in the peritoneal space, in the pericardial space, in the pleural space? Is there or is there not pneumothorax? So you're looking to answer 4 questions. So very specific answers to specific questions. Okay. The highest yield is in your unstable trauma patients. So remember the traditional indication for your FAST exam, thoracoabdominal trauma with evidence of instability. That's where the highest yield for the FAST exam is. Okay. But again, the FAST exam is starting to be used in more broad situations, including non-traumatic situations, where you're trying to figure out why someone is in shock. Okay, remember the specificity in that setting is going to be significantly lower because the ultrasound cannot differentiate between blood and ascites, for example, especially if the blood is fresh. Okay, so if you're dealing with a patient in the MICU who is unstable and has a dropping hemoglobin, if you look and find free fluid in the belly, it's possible it's blood. It's also possible it's just ascites from being in the ICU and being, volume overloaded for so long. Okay, so take your pretest probability into account when you're interpreting the findings of your FAST exam. Okay, of course it is rapid. So remember we talked about the acronym for FAST, focused abdominal sonography and trauma, but FAST is also a descriptor of the study. It's a fast exam. Your idea is to get in and get out quickly to get quick answers. Okay, and it is repeatable. So remember, the thing that really increases the yield for any point of care ultrasound study, especially the FAST exam, is the fact that you repeat it. You repeat it every time something changes, or if you're trying to monitor a patient, for post-traumatic bleeding, doing serial FAST exams really increases the yield of the study. Okay, the things that the FAST does not do, it does not rule out injury. Okay, so just because there's no free fluid or blood in the belly or chest does not mean that there is not traumatic injury to the belly or chest. It does not localize injury. So just because you have free fluid on the right side does not mean your lesion is on the right side. Okay, blood can flow quite freely through the peritoneum, so it does not necessarily localize it. Remember, I said, fluid on ultrasound looks the same whether it's blood or not, especially when the blood is fresh. Eventually, if you have hemopericardium, over time, what's going to happen is the cellular elements will start to drop dependently by gravity, and you'll develop a sort of a meniscus sign, but that takes hours to happen. If you're dealing with someone that's acute after an event, fresh blood and free fluid of any other kind, like ascites, cannot be differentiated on ultrasound. So remember that when you're applying this in the non-trauma setting, okay? Like any ultrasound study is both operator and patient dependent. So if you suck at it, your yield is going to suck. And if you have a patient who is difficult because of body habitus, because of cooperation, that type of thing, the study itself is going to be limited. Okay, and certain injuries make the FAST exam more difficult to do. For example, if you have free air in the belly, you're possibly not going to be able to see the structures that you want to see, like the splenorenal space, the hepatorenal space, that type of thing. If you have a bunch of A lines obscuring your views, that may make the exam itself limited. But if you see a bunch of A lines where you're supposed to be seeing liver, that in itself may give you some evidence that there is injury. Okay, so that is my FAST talk on the FAST exam. If you have any questions, don't hesitate to shoot me an email or come find me. And I look forward to scanning with you.